afternoon, everyone. Thank you for joining us at the Knight Cardiovascular Institute Grand Rounds. It is my distinct pleasure to introduce our speaker for the fifth time. I'm getting tired of hearing myself give speaker introductions, but so my sympathies to the rest of the Division of Pediatrics who's heard this so many times, but alas. It is a distinct honor to introduce our speaker today, Ms. Diane Spicer. She is our speaker for the Kasdan Lecture Series, which, as we know, is a lecture series in which we bring luminaries from across the world to educate us on congenital heart care as a memorial lecture series for a patient who's cared for this institution many years ago. Ms. Spicer is a pathologist assistant at Johns Hopkins All Children's in Florida. She is also a preeminent cardiac anatomist who is really one of the leading figures internationally and nationally in the field of cardiac morphology and dysmorphology. She maintains multiple libraries of specimens, of which we've been able to appreciate many during this visit, and it's been a really educational and wonderful several days. And so today, or this evening, she's going to educate us on normal cardiac anatomy in a deep dive to the intricacies therein. And with that, please join me in welcoming Ms. Diane Spicer.
Okay, for those of you who have been here for the last couple of days, some of this is going to be initially repeat with some of the special dissections you've already seen, but there is additional special dissection relative to some of the very internal structures of the heart. So hopefully the repeat of things will just lead us to some of this intricate anatomy. So I have no disclosures. You're probably thinking, I know the anatomy of the normal heart. So I hope that I can enlighten you on some of the structures that we don't typically look at and how looking at some of these structures is leading us to more personalized medicine. And so a number of years ago, I was sent this image from Shumpai Mori. It's a CT rendering. And I was asked if I could repeat this dissection. So we actually had opportunity to look at this heart that I did dissect to match Shumpai's image. And there you can see the membranous septum that I've encircled in kind of the same color of green that he has marked the membranous septum. So they were starting to look at the arterial roots, particularly the aortic root, relative to some of the surrounding structures, namely especially the conduction tissue, with regard to transaortic valve replacement and how they could assess morbidity and mortality by looking at a person's CT before they had their TAVR. And so we'll get to that at the end of this presentation. So we've already talked about learning what is normal and looking at the heart as it lies within the body, because that's how we look at it on echo, CT, MRI. So an attitudinally correct orientation. We use the morphologic method to identify each of the segments of the heart, and we use sequential segmental analysis as we're looking at how the segments are connected. But today we're going to focus a bit more on looking at the septums and the conduction tissue eventually, the atrial and ventricular components of the septum and how they're related relative to the conduction tissue. So one of the first rules of human anatomy is that all bodily parts should be described as viewed in the so-called anatomical position. Oh, excuse me. So if we look at the long axis of the body, we can see that the ventricular mass relative to that extends or is directed from right posterior to left anterior. The aortic root forms the centerpiece of the heart, and the pulmonary trunk is anterior and leftward of the aorta. The left atrium is the most posterior chamber of the heart, and the right-sided structures are in part right-sided, but are anteriorly positioned. So if we use those rules of human anatomy, why do we still use the standardized approach for all areas except for the heart? So if we take the heart, as many of us were taught anatomy in our training, it typically is taken out of the chest and put in the Valentine position with the apex down. And I have the coordinates there to help us navigate through this. And so this is why we ended up with a right ventricle and a left ventricle, because old anatomists took the heart out of the chest and put it on its apex. So that is now considered inferior, when the diaphragmatic surface is actually the true inferior surface of the heart. So examination of cardiac structures can be performed in 3 orthogonal planes. As you guys all know, you look at the echoes in all of these planes. And anatomic dissection, as far as the heart and the remaining organs of the body, have their limitations. Once I cut the heart, I have to glue it back together to cut it in another plane. So when you have all of these imaging modalities at hand, there are infinite possibilities for you to look at these structures. And so you see I have here a 4-chamber, a peristernal long axis, and a short axis from the apical view. And so you guys can do this without cutting the heart, but once I cut it, it is what it is. So now I have the heart. We're looking at it from the apex towards the base. And you can see the diaphragmatic surface, which is inferior, the sternocostal surface, which lies against the sternum anteriorly. The obtuse margin takes us around to the posterior surface. And is this really the posterior descending artery? It lies against the diaphragm. And when you look at an ECG of a patient that has a myocardial infarction in this area, it tells you that it's an inferior myocardial infarction. So I don't know why over all the years people are still calling it the posterior descending coronary artery. So this is a short axis view from the base. And again, you can see the diaphragmatic surface, the sternocostal surface, and the aorta is the centerpiece of the heart. Again, you can see it's deeply wedged between the atrioventricular valves. There's the pulmonary trunk, and you can see how it spirals around the aorta from the right towards the left. There's the tricuspid valve and the mitral valve. This is looking at the heart from the lateral aspect. So there are the superior and inferior cable veins, the right pulmonary artery, the right pulmonary veins, and the left pulmonary veins. And you can see the right atrial appendage with the terminal groove. Anterior to that, inside the atrium, will be the terminal crest. And there you can see that interatrial groove, which we're going to focus on a little bit. And that's typically known as either Sondergaard's or Waterston's groove. And surgeons can use this interatrial fold to access the pulmonary veins or the mitral valve. So this is a little bit of repeat, but we assess the anatomy of the cardiac components by using the 3 segments that are the atriums, the ventricles, and the arterial trunks. We use sequential segmental analysis, which allows each segment of the heart to be assessed separately, and as well, how each of the segments are connected to one another. The morphologic method plays really nicely with sequential segmental analysis. And as we've already defined, it states that you should not use one variable feature to define another feature, which is itself variable. So we use the most constant component of each of the segments for the definition or the morphologic characteristics of that chamber. So as we all know, the atriums have a body which is very small in the right atrium. They have a venous component, an appendage, a vestibule, and the cavities are separated by a septum. And there are actually extensive interatrial folds, as we saw on Tuesday with our normal heart demonstration. But the most constant component is the appendage and the extent of the pectinate muscles. This is an anterior view of that same heart we saw in the lateral view, and you can see the location of the sinoatrial node at the cavoatrial junction, just in the top of that terminal groove. There is the appendage, which is the entire anterior aspect of the right atrium and the appendage. There's the terminal groove. There's the interatrial fold, or the interatrial groove, Sondergaard's or Waterston's groove. And now we can see a comparison with the left appendage. It's that tubular appendage with the narrow junction to the venous component, or where the pulmonary veins drain to the left atrial vestibule. When we look inside of the right atrium, there is the venous sinus. There are the pectinate muscles radiating from the terminal crest, which I have marked in red. And you can see them surrounding surrounding the right atrioventricular junction. There's the oval fossa, and there's the atrial vestibule. And so there are two smooth components within the right atrium, that venous sinus I have marked with the black dotted line, and the atrial vestibule. So the atrial vestibule, or the pectinate muscles, I should say, are what separate those two smooth components. The vestibule is between the distal extent of the pectinate muscles and the hinge point of the tricuspid valve, but they separate it from the smooth-walled venous sinus or venous component. And if I have, there is the body of the right atrium. And if you look in the right atrium, this right atrium actually has quite a large body. So it's that area between the inferior extent of the oval fossa and where the inferior caval vein joins the right atrium. And a lot of times you can see some little fenestrations here, or some trabeculations. And those are actually the left venous valve that has not totally resorbed within the body of the right atrium. And I have seen, and I have a couple nice 4-chamber sections, not in this lecture, but in my collection, where the left venous valve doesn't totally resorb, and it will cover with a separate membrane the flap valve at the floor of the oval fossa. So it's very interesting that I never used to look for that in the past, but now we are really looking at all the venous valves as we see them in the right atrium, because everything is shifted venous-wise to the right atrium during development. So it's amazing what you overlook until you start doing certain special dissections and looking at the embryology. So here we see the left atrium, which is opened. You can see the pulmonary veins from the right and left joining the roof of the atrium. There is the left atrial appendage and its narrow junction with the venous component. And the pectinate muscles are confined to the appendage. The body of the left atrium is much larger on the left, and it is that area between the appendage and the atrial septum, and the atrial vestibule on the left is smooth around its entirety. There is the horseshoe structure where the flap valve overlaps that superior interatrial fold, and we will look at those folds here in a minute. When we assess the anatomy of the ventricles, we know that they have an inlet, an outlet, and an apical trabecular component. The cavities are separated by a septum, the majority of which is muscular, and the membranous septum, which is the smallest component of the interventricular septum, and also has a component that is atrioventricular. The atrioventricular valves go with their ventricles. So the tricuspid valve is morphologically right, and the mitral valve is morphologically left. The most constant component, as you guys have heard, is the apical trabecular component. So if we compare the right and left ventricles here, you can see that they both have inlet components, and the inlet component extends from the hinge line of the atrioventricular valve to where the papillary muscles attach to either papillary muscles or the interventricular septum in the case of the tricuspid valve. The outlet typically supports the arterial trunks, and they both are supported in different ways. The pulmonary valve by a subpulmonary muscular infundibulum or a complete muscular sleeve, and the aortic valve has muscular and fibrous support. The apical trabecular component is our most constant component. So on the right, there are very coarse apical trabeculations, and often the septal surface is trabeculated, whereas the left has fine and crisscrossing trabeculations. If we look at the atrioventricular valves on a short axis apical view, we can see the septal leaflet of the tricuspid valve, which lies against the septum, as its name tells us. The largest leaflet of the tricuspid valve is the anterior superior leaflet, and the smallest leaflet is the inferior leaflet, which lies against the diaphragmatic surface. Some people refer to this as the posterior leaflet, but that is anatomically incorrect. So here you can see the mitral valve. The mural or posterior leaflet makes up about 2/3 of the circumference of the mitral valve, and the remaining third is the anterior or the aortic leaflet, and it's referred to as the aortic leaflet in some cases because of that aorta to mitral fibrous continuity. And I know that Professor Anderson prefers it to be called the aortic leaflet rather than the anterior leaflet. And people will always pose him the question, well, what do you call it when you have transposition? He calls it the pulmonary leaflet. So I usually put both names out there as not to upset anyone. So the papillary muscles, if we look at the heart in attitudinally appropriate fashion, are actually supero-posterior and infero-anterior, and not superolateral and posteroseptal. So those terms are anatomically incorrect. I don't know that we're ever going to change any of this nomenclature, but as we train new people, we are trying to put that out there so that they may adopt it. And as you guys were having just conversation here earlier, it does take quite a bit of work or thinking to get everybody's mind going in the same direction. And even myself, as Professor Anderson has changed terminology over the years, I really have to think about some cases on what I'm supposed to call things to be anatomically correct as a morphologist. You can also see at the ventricular septum that the right ventricular inlet is separated actually from the left ventricular outlet. The arterial trunks are identified by their branching pattern, the pulmonary trunk to the right and left pulmonary arteries, and the aorta first to the coronary arteries, and then the brachiocephalic arteries from the arch. So as we have talked about, we know initially the cardiac structures initially have a double inlet to the left ventricle and a double outlet to the right ventricle. And we eventually have to move these things around so that both ventricles have an inlet and both ventricles have an outlet. So in the scope of this, we are going to talk about the atrial septum and its true components, as well as the interatrial folds, and also the intricate anatomy that we see at the floor of the triangle of Koch, or that space that's called the inferior pyramidal space. And this has a lot of implications as far as where the conduction tissue lies and where we can observe this in the subaortic and atrial septal anatomy. The ventricular septum, as we've already mentioned, has a membranous component, which is the smallest, and the muscular component is the largest. I think you guys have heard me mention the inferoseptal recess, and that is that triangular space that lies adjacent to and extends inferior to the right fibrous trigone, or where the mitral valve was anchored in the left ventricular outflow tract. And we're going to compare the apexes of the inferior pyramidal space and the inferior septal recess, and how this is very deep, intricate anatomy of the normal heart. So if we look at this four-chamber view, we can see the secondary foramen. Now, as the primary septum breaks down at the roof of the atrium, there's the mesenchymal cap, the vestibular spine, and the primary foramen. So when all of those things in the atrium fuse normally, we end up with the mesenchymal cap, the vestibular spine, the primary septum, and the atrioventricular cushions closing the primary foramen. And actually, these structures are what form the vestibules of each of the atriums. Without this, or without this normal formation, you don't have separate right and left atrioventricular valves. So this is what we end up with definitively in a four-chamber view, with the normal offset of the atrioventricular valves and a separate right and left atrial vestibule. You can see the pulmonary veins entering the roof of the left atrium. There's our superior interatrial fold, which we'll explore a little bit deeper in a minute. And you can see where the flap valve overlaps that superior interatrial fold as it closes the oval fossa or the oval foramen. And there's our muscular buttress, which it comes from those structures fusing with one another. And when we look at the atrial septum, this is an open right atrioventricular junction. You guys can see the coronary sinus and the oval fossa, but many people think that whole blue area is what makes up the atrial septum, when in reality, most of this is interatrial folds. So that is marking the right atrial vestibule, or that smooth area between the distal extent of the pectinate muscles and the hinge line of the tricuspid valve. There's the venous sinus between the cable veins. And there is the lateral aspect of the oval fossa, which actually is part and parcel of the interatrial folds. There's the flap valve, or the primary atrial septum, the anterior inferior rim, or the limbus of the oval fossa, and that is joined with the second true component of the atrial septum, or that muscular buttress, which we know is formed because the mesenchymal cap and the vestibular spine join with the atrioventricular cushions. So the triangle of Koch is one area that we use to mark where our atrioventricular conduction axis is. So you can see one arm of the triangle is marked by the eustachian valve, but with a tendon that lies deep to it, which is called the tendon of Totaro. And there is the hinge point of the tricuspid valve. So you can see the arms of the triangle with the coronary sinus mouth at the base, and that at the apex, the star, is where our atrioventricular conduction axis is going to be located. So this is one of the dissections that I showed you, showing where I have pulled apart the interatrial folds along that Sondergaard or Waterston's groove. And you can see that very light ellipse marking the true atrial septum, or the primary septum, or the flap valve at the floor of the oval fossa. There are the pulmonary arteries. I've pulled the arterial trunks forward so you can see the transverse sinus. So this fold extends actually beneath Bachmann's bundle, which is are those parallel muscle bundles that run anterior to the atrial structures and play an important part in conduction between the atriums. There is a portion of the pericardial flap, and you can see the terminal groove and those extensive folds. When I tilt the heart up a bit, you can see there's another fold between the inferior cable vein and the coronary sinus. The black area in that atrioventricular groove is marking where the coronary sinus lies, deep to that atrioventricular groove fat. And there you can see that this fold extends between the inferior cable vein and the coronary sinus, and sometimes people refer to this as the sinus septum. Now we're going to get into some of the areas where I'm doing dissection of these folds. So you can see I've removed a piece of the atrial endocardium or endocardium so that we can see the inferior pyramidal space or the floor of the triangle of Koch. There is the markings of the triangle of Koch. There's where our atrioventricular conduction axis will be. When we remove the remainder of those folds, you can see the markings of the triangle of Koch. And now I've removed most of the eustachian valve, but you can still see where this tendon is running. And it will actually attach itself into the central fibrous body or very near that right fibrous trigone in the left ventricular outflow tract. I have lifted away the atrial wall where the cavoatrial junction is so that now you can see the area of the transverse sinus right here, anterior to the atriums and posterior to the aorta. And those are all, those areas marked in black are where I've removed the right atrial wall, showing us the extent of the interatrial folds, so that the true atrial septum is marked at the oval fossa and that anterior inferior muscular buttress that's formed by the mesenchymal cap, the vestibular spine, and the atrioventricular cushions. So I've also illustrated here that at the atrioventricular grooves, there's a lot of fiber fatty tissue that protects the coronary arteries. And so that this fiber fatty tissue from the atrioventricular groove actually extends into the inferior pyramidal space. So all of this area that was lying over this component of the interatrial groove was actually part of the right atrial appendage that I've now removed. So this is back to that first dissection that I showed you, that I'm now going to take the heart and cut it in these three planes to show you what the four-chamber anatomy looks like. So this is the most inferior cut. You can see the inferior interatrial fold between the inferior caval vein and the inferior aspect of the left atrium, with the right lower pulmonary vein there towards the top. That is the fiber fatty tissue continuing in between the inferior caval vein and the coronary sinus towards the inferior pyramidal space or towards the floor of the triangle of Koch. You can see the roof of the inferior septal recess. And actually, very nicely in this area, you can begin to see where the tricuspid and mitral valves are in fibrous continuity. This is a cut that's a little bit more anterior. So again, you can see the inferior caval vein. There's the muscular buttress. The mouth of the coronary sinus is inferior to that. And there is the artery to the atrioventricular node, which runs along the floor of the inferior pyramidal space or in that fiber fatty tissue that's extending from the atrioventricular groove. So if there's a right dominant coronary system, the atrioventricular node artery will extend from the distal right coronary. And if there's a left dominant system, it will extend from the circumflex artery. So here is the area I learned early on that was called the atrioventricular muscular sandwich. So you might think it's a strange name, but it actually illustrates the anatomy very nicely, because there you can see the atrial vestibular myocardium is the bread, and the ventricular myocardium is the bread on the other side. So the meat is actually the fiber fatty tissue that's progressing towards the apex of the triangle of Koch and lying at the floor of the inferior pyramidal space. And I can show you this microscopically. So there you can see the fat extending in from the right atrioventricular groove beneath the mouth of the coronary sinus. The atrial myocardium and the ventricular myocardium are the bread. And there's your fiber fatty tissue extending in from the right atrioventricular groove. That is the meat of that atrioventricular muscular sandwich. This is a cut that's a bit more anterior, that third line that I drew across the atrium. And now you can see a bit of the aortic root. There's the interatrial fold, which is more superior. You can see the pulmonary veins are still draining into the left atrium relative to that fold. You can see the very inferior component of the atrial septum, or the primary septum, where it's overlapping that interatrial fold. There is the aorta to mitral fibrous continuity. There's a portion of the aortic valve. The membranous septum is there with the tricuspid valve crossing it, and we can now see the interventricular and the atrioventricular component. And I don't know if my animation is going to show it, but right here is that inferior pyramidal space. You can see right where the right fibrous trigone is located relative to the fibrous tissue of the membranous septum, which typically is beneath the interleaflet triangle between the right and the non-coronary valvar sinuses. So this dissection, I've split the heart in half, and so this is the right ventricular half, and it has the ventricular septum attached to the other side of it. So the red line is marking where I've removed the primary atrial septum, and I've left the muscular buttress intact. There is the subthebesian sinus, and you can see those pectinate muscles extending all the way to the crux of the heart. And you can even appreciate the very thin, almost transparent atrial endocardium here, where there's fiber fatty tissue extending from the atrioventricular groove into that floor of the triangle of Koch, or the inferior pyramidal space. So this is the opposite side of that section I just showed you. And you can see now where the primary septum was. There is the inferior pyramidal space and that fiber fatty tissue extending from the atrioventricular groove. And there's the muscular buttress. The muscular buttress serves as the support of the area where the tricuspid and mitral valves are in fibrous continuity. You can also see the membranous septum and a little piece of the mitral valve that I've left attached, so that the inferior septal recess is right here. This is the left ventricular component of that same dissection. And you can see now where that little piece of mitral valve was removed. There's the muscular buttress, and there's the muscular rim of the oval fossa and the primary septum that I've left attached to this left ventricular component. And now you can nicely see the mitral to aorta fibrous continuity, and where that yellow dotted circle is actually in the area where the right fibrous trigone is located. And so again, on this side of the dissection, you can see the fiber fatty tissue extending from the inferior pyramidal space into the floor, or the floor of the triangle of Koch, or the inferior pyramidal space. So as we've mentioned, the aorta is the centerpiece of the heart. And you can see how it's deeply wedged between the atrioventricular valves. And it also remains atop a portion of the muscular ventricular septum. So we've seen these slides before, how the outflow cushions will fuse and close the septum. And you can see how the aorta is still riding over the septum just a bit. There is the muscular inner heart curvature that will eventually resorb to become the aorta to mitral fibrous continuity. And if I compare this image with a normal heart that I've cut in a kind of 5-chamber echocardiographic view, you can now see the aorta to mitral fibrous continuity. And there is where the aorta, the right coronary valvular sinus, is actually overriding or sitting on the septum in the normal heart. If I would cut this a little bit more inferior, we would be able to see where the membranous septum would be located. So we've talked about the outflow cushions muscularizing to lift the pulmonary valve up off of the right ventricular mass and then move the aorta into the left ventricle, with the tubercles of the atrioventricular canals eventually closing that VSD and forming the membranous septum. And here is the definitive heart developmentally. You can now see the right ventricular inlet, the subpulmonary infundibulum, the ventriculoinfundibular fold, and the septomarginal trabeculation. And we've talked quite a bit about this throughout the last day and a half. So this is the beginnings of that dissection that Dr. Maury asked me to reproduce. All right, I think it's there. Maybe, maybe not. But there's the septomarginal trabeculation, cephalic limb, caudal limb, subpulmonary infundibulum, ventriculoinfundibular fold, and you can see where that supraventricular crest or those outflow cushions inserted themselves normally into the right ventricular septal surface, or the apical component of the interventricular septum. There's the medial papillary muscle, the septoparietal trabeculations, and the membranous septum. So this dissection we also talked about, and this shows us that it's not possible to recognize a muscular outlet septum in the normal heart. So the cushions, we know, insert themselves between the limbs of the septomarginal trabeculation, and when those structures become divorced from one another, this is when we end up with a prominent outlet septum. So there's the supraventricular crest, ventriculoinfundibular fold, subpulmonary infundibulum, and you can see where I've removed the right coronary valvular sinus, and the muscle supporting it is marked with the black dots. And you can see that there is a nice fibrofatty tissue plane between all of those structures within the outflow tract, so no potential for an outlet septum. There's the interventricular component of the membranous septum and the atrioventricular component. So if we look at the aortic root, we can get more specific with some of this anatomy. There are the right and left fibrous trigones where the mitral valve is anchored within the left ventricle or the left ventricular outflow tract. There's the membranous septum, and there's the inferoseptal recess. So the central fibrous body is typically referred to as the fibrous tissue between the membranous septum and the right fibrous trigone, and the roof of the inferoseptal recess, or the base of that triangle, is formed at the central fibrous body. So if we go back to the atrial dissections, we can now see the muscular rim of the oval fossa, the muscular buttress, and now you can see the triangle of Koch, and the tendon of Totaro will become more prominent as I dissect through this specimen. You can see the right coronary artery in the right atrioventricular groove, and there it is extending at the floor of the inferior pyramidal space through that fibrofatty extension towards the atrioventricular node. Certain pathways that affect conduction in the atrium run in the septal isthmus and in the cavo-tricuspid isthmus. And this is looking at this on short axis. So now we can see the tendon of Totaro, how it's extending beneath the eustachian valve and towards the membranous septum. It's beneath or extending into that muscular buttress. This is even further dissection where I've removed the tendon of Totaro. And so you can see the artery to the atrioventricular node. I've removed the fibrofatty tissue here. You can see how that artery lies on the crest of the muscular ventricular septum. So the only connection between the atriums and the ventricular septum is the muscular buttress. And that muscular buttress, as I've already mentioned, supports the area of fibrous continuity between the tricuspid and mitral valves just beneath there. This is even further into the dissection. So you can now see the tricuspid to mitral fibrous continuity where I've removed that muscular buttress that was supporting that area. You can see the tricuspid valve and a little bit of its vestibule remaining. There's the inferior pyramidal space, or the floor of the triangle of Koch. And now some people who are participating in some of this anatomy are calling the triangle of Koch the pyramid of Koch, because it's actually where all that fibrofatty tissue is in the folds, makes a pyramid. So you can see the right coronary artery and the artery to the atrioventricular node. And there is the inferoseptal recess, where I've removed that little portion of the mitral valve so we could see where that triangle was in the left ventricular outflow tract. This is the same dissection, but I've just removed the area of aortic valve and atrial musculature to show where the non-coronary valvar sinus is in fibrous continuity with the aortic root. So if we look at this dissection compared to a CT rendering of the same structures, we can see where the conduction tissue is located. So that's where our atrioventricular conduction axis will be located, at the apex of the inferior pyramidal space, or triangle of Koch, and just about in that area where the fibrous continuity of the tricuspid and mitral valve is located. So at the apex of each of those triangles, the inferior pyramidal space and the inferior inferoseptal recess. So there is the non-branching bundle, or the bundle of His. You can see the penetrating bundle leading to the right and left bundle branches. And there are the left and right inferior extensions. And you can see all of that marked on this amazing CT rendering done by Dr. Justin Tretter, and appearing in that reference I have listed there. So when we look at the septal surfaces of both the right and left ventricles, you can see where the atrioventricular node will be located, more within the atrial myocardium, and at the apex of the triangle of Koch. So we can see on the right the bundle of His, or the penetrating bundle, and where it is located relative to the left ventricular structures, or that central fibrous body. There's your non-branching bundle. The left bundle branch, you can see, extends along the crest of the muscular ventricular septum, very often related to the nadir of the right coronary leaflet before it begins to trifasciculate over the crest of the ventricular septum. I probably should extend that left bundle branch a bit more, but it depends on where the membranous septum is and how big the membranous septum is, as to how close that left bundle branch will run to the nadir of the right coronary valvar sinus, or leaflet. There you can see the origin of the right bundle branch, and that is relative to the medial papillary muscle, and then it will extend down the septomarginal trabeculation into the moderator band, and then send branches into the right ventricular apex. And sometimes people end up with a dead end tract, which is just a developmental remnant, and these areas have been thought to cause some arrhythmias. So these are some of the dissections that were compared to microscopic sections relative to the membranous septum and the nadir of the valvar leaflets. Those green lines are marking the virtual basal ring, or the echocardiographic annulus. And so you can see in those three hearts, there is quite a bit of difference in the extent of the membranous septum relative to the inferoseptal recess and the central fibrous body. So here, the muscular septum is very close to the virtual basal ring. Here, it's a bit farther away, and here, even farther away. So these patients that have a larger membranous septum would have expectedly the conduction tissue farther away from where a transaortic valve replacement would be seated within the aortic root. So these are just some of the CT renderings that were done by Justin, showing all of the different components so that the it was simulated in some of these dissections where you could see the transaortic valve replacement was put in to the dissection. The light blue areas are marking the membranous septum. You can see that the non-branching bundle is marked in yellow, the branching bundle in white, and then the superior fascicle in red. And in some of these dissections, it just shows how close and how far away, depending on the anatomy of the membranous septum and the aortic root, where these patients can be evaluated for increased mortality and morbidity or very good outcomes. I kind of lost my train of thought there for a minute. And we've also looked at many, many aortic roots. So where I was going with my train of thought is that the muscular and fibrous support in any of our aortic roots can be very variable. And there is so-called clockwise and counterclockwise rotation. And we have a few dissections that have shown very increased muscular support. And when you have increased fibrous support, I have a couple of cases that have sinus of Valsalva aneurysms because of that increased fibrous tissue and actually more movement of the aortic root because of lack of the fibrous support. So it was just very interesting for me to participate in some of these dissections relative to the muscular buttress, the tricuspid and mitral valve fibrous continuity, and both of those triangles, the inferior pyramidal space and the inferior septal recess, and how closely they all are related to the aortic root anatomy and the conduction tissue anatomy. And I have listed a few of the references here, and those are some of the same images that I showed that I was able to participate in with some of the actual specimen dissections. So looking at the heart in attitudinally appropriate fashion allows us to put all the building blocks together in place and for comparing the anatomically dissected specimens to those that are virtually dissected. And this has actually been a lot of fun for me, and I've learned a lot about the very intricate anatomy of how the atriums are attached to the ventricles and how there are very large folds that we never usually consider. And understanding the concepts of embryology are important with respect to normal and congenitally malformed hearts. And if you think about when Professor Anderson talked to us about the expansion of the right atrioventricular junction, when you have an atrioventricular septal defect, that junction doesn't expand so far, and you don't have that inferior pyramidal space. You don't have that extension of the fat from the AV groove going in to the right atrial vestibule. So the differences in anatomy, if things don't expand right or develop right, can be quite detrimental when you're having these personalized medicine assessments for people to have interventional procedures done. So just use of simple anatomic terms makes it easy for all of us to understand each other. And as we've been talking about the last few days, that's probably the most important thing, that we should all be able to understand each other and what we're talking about as far as anatomy in both the normal and the congenitally malformed heart. So thanks for your attention. And if you have any questions, I know a lot of that was repeat, but hopefully it showed you some stuff you didn't realize where it was there. It really kind of blew me away when I did these dissections that there's only that little chunk of atrial myocardium that's connecting the ventricles. and that where that inferior pyramidal space is, all that fat is just sitting on top of the ventricular mass. So it was just a lot of fun for me to do, and I hope it was fun for you guys to see it.
Thank you. I think we have some time for questions. I'll kick us off. How is it in the setting of, I know this is an emphasis on normal anatomy, but can't help but ask an abnormal question. The outlet VSD with perimembranous extension, your slides would lead me to believe that would totally interrupt the fibrous curtain of the heart. How is it that the semilunar valves are able to maintain their stability in that setting?
It does interrupt the membranous septum, and depending on how inferior that defect extends towards the inlet, that shortens that inferior pyramidal space. So the conduction tissue gets pushed in that short apex of the triangle of Koch, it gets pushed inferior. So there is disruption, but still the inferior septal recess remains where the mitral valve is anchored in the roof of the left ventricle. It may be shorter, it may not be as long, but the membranous septum is definitely disrupted in perimembranous defects. But you can still see in most cases an inferior septal recess.
Thank you for that great talk. I wonder if you've seen enough variation in bundle branch to explain why some people might be vulnerable for a blockage, and if that's got an anatomic basis in your mind.
I haven't looked at a lot of histologic sections of the conduction tissue, so I don't know that I can adequately answer your question. I just have looked at kind of the anatomic details in these dissections I was asked to do. I know there is some variation in the way those things are formed and the length of the bundle branches. If the membranous septum is unusually large, I think that left bundle branch, it does extend quite a bit along the crest of the muscular septum before it trifasciculates. But in those cases, with a large membranous septum, it's usually farther away from the aortic root, which makes that person less vulnerable to a bad outcome with a interventional procedure. We haven't talked about the development of the atrioventricular conduction tissue a lot at this session, but when it forms, it is surrounding that initial interventricular communication. And when the right atrioventricular canal expands, it's like the picture of the melting clock. And so it's really, I really have to think about it when I think about the developmental components, because if I was able to show you some pictures, you can immunohistochemical staining to see where it was surrounding the initial interventricular communication. And when that right atrioventricular canal expands, that's how you end up with the look of the melting clock. And so some of those pathways regress, hence the dead end tract in the subaortic region, and some of those inferior extensions. So it's really kind of interesting, and I'm actually still learning more about the conduction axis myself. So sorry if I couldn't totally answer your question.
Final round of applause, and we'll bring the day to a close.